Hi, my name's Phillip Read. I'm the director of the Kirketon Road Centre, which is in Sydney, Australia, and I'm delighted to have been invited today to talk about our integrated blood-borne virus care and harm reduction programme for vulnerable populations. Kirketon Road Centre, as I said, based in Sydney, Australia, it was established in the King's Cross area of the inner city over 30 years ago. And it's an integrated primary healthcare service which aims to meet the health and social welfare needs of a group of vulnerable young people, people who inject drugs, sex workers, and also sees many people from the local homeless, Aboriginal or LGBTI communities. Key to the service is also an integrated opioid agonist treatment program with a particular focus on access to care. So we often see people who have had problems accessing some of the more mainstream drug and alcohol services. We have a large hepatitis C, HIV and PrEP program and offer a range of prevention testing and treatment support options, including daily dosing. We operate a harm minimization model, a particular focus on harm reduction. And in terms of size, we're a medium-sized service seeing about 4,000 individuals, about 20,000 appointments a year, and almost half of those people are individuals who've recently injected drugs. But across the broad service, we've integrated mental health, counselling services, we have a legal clinic, social work, we operate the district's needle and syringe programme, and important principles about the model of care are that we are free, confidential, walk-in, and a one-stop shop model. Now, we've always taken a population versus a disease-focused approach, so we aim to meet the broad range of health and social needs of people at risk of blood-borne viruses, not just the blood testing and treatment of the blood-borne viruses themselves, and recognising that the health of these individuals clearly encompasses a broad range of physical, emotional, and social aspects of well-being. Because in Australia, some of the activities that people who come to our service are involved in are either illegal or highly stigmatized, we offer the opportunity for people to be anonymous where they desire that. And we have very flexible drop-in appointments and extended clinical hours to suit all different types of lifestyle. The care model is very multidisciplinary, so we have joint teams of doctors, nurses, social workers, counsellors, an increasing number of peer workers and health educators who all work together focused around individual patient care. Now, we operate the classical alma mater primary health care philosophy, recognising health as being a state of physical, mental and social well-being and not merely the absence of disease. And therefore, we always frame the work that we do in terms of whether it's acceptable, accessible, affordable and equitable to the populations that we're wishing to provide care to. And just to frame that a little bit, I thought I'd provide some examples of our work that tries to encapsulate some of these important principles. So in terms of accessibility, we're located where it says KRC in the middle there, which is in the middle of the inner city of Sydney. But recognising that we need to deliver care at the point of at multiple points of access to the system for people at risk of hepatitis and HIV, we provide outreach services to all of those other locations that are detailed on the map, and that's all within about a 5 kilometre square radius. So there's multiple opportunities to be engaged wherever that person is that day across a suite of services in the inner city. We also focus predominantly on affordability as well. So all of our services are free and anonymous if necessary. And we try to provide as much of the medication as we can for free as well. The hepatitis C medications are provided through the Australian government, but in Australia, there is a co-payment required for many people to access these medications, which for some is not significant, but for many can actually be a barrier to accessing hepatitis and HIV care. So we've supported that cost for 300 or 400 individuals who we've treated for Hep C over the last couple of years. And we found that the populations who most benefited from this support around the finances related to treatment were people who were homeless, people who recently injected drugs, people who were currently receiving opioid agonist therapy, and people who identified as Aboriginal. And through providing financial support to people integrated into our hepatitis C and HIV program, we were able to ensure that treatment completion was maintained in groups where one might expect lower treatment completion rates. We also very much wish to ensure that our Hep C HIV program for people who are people who inject or people who are homeless is acceptable to them. And so we have a client consumer group who advise us and work with us around the delivery of care in the service, and co-produce many of our activities, clinical services and resources. And we also come up with an individualized dosing plan for somebody so they can dip in and out of daily dosing, weekly dosing or monthly dosing for their HIV or hepatitis C meds, according to their often changing social circumstances. We also offer pickup of medications from both the Kirketon Road Centre main site, local pharmacies, our New South Wales users, our drug user organisation, NUA, and also the medically supervised injecting centre, which is close by. We've also tried to make testing for HIV and hepatitis C as acceptable as possible, and so have multiple testing options, including standard rapid tests, but also dry blood spot finger prick tests that go to the laboratory for an HIV antibody test and a Hep C RNA test, and we've conducted many hundreds of those. We also work closely with peer-based organisations, both employing peers ourselves and also working with peers from elsewhere, and found that's been a very effective way of engaging individuals into integrated care. And we've also developed a programme for people who are housed, but are perhaps housed in marginal housing situations, where we're able to deliver testing and treatment to their home environment via a mobile outreach van. The graph here just comes from a paper where we've looked at the outcomes of dosing daily for marginalised and vulnerable populations through our opioid agonist treatment programme, demonstrating adherence that was sufficient to ensure virological cure for hepatitis C in the overwhelming majority of patients. This is an example of the personal assessment plan we conduct for people who are undergoing hepatitis C treatment. And very much it focuses around where their social situation is, how they can be contacted, and what the milestones for them will be as they progress through hepatitis C treatment. So it's very patient-centred, and we try to be as flexible as possible in delivering aspects of care. And we've also evaluated the effect of integrating the Hep C treatment program within a peer-based needle and syringe program run by our partner organisation, NUA. And we found that access to primary healthcare and comprehensive primary healthcare and hepatitis C treatment within that needle and syringe program setting was highly accessible and acceptable to that drug-using population locally in Sydney. We also have a focus on equitable healthcare, trying to ensure that everybody is able to reach the same level of improved health. And one of the populations in Australia it's always important to consider are Aboriginal people. And we therefore evaluated our program looking at aspects of the hepatitis C care cascade, comparing whether or not that is equitable between Aboriginal and non-Aboriginal Australians. And as you can see from this data, the results are equivalent. We employ Aboriginal staff, and we work closely with other local Aboriginal organisations to ensure that our integrated hepatitis C care program is culturally informed and culturally appropriate. Much of the care provided is through nurse-led outreach services, as described in the geographical slide I showed some slides previously. We did want to look at both the contribution of nurse-led care and also the other services that our clients accessed as part of their integrated care experience. And so the data here relates to an analysis of the first almost 400 individuals that we treated for hepatitis C, looking at the proportion of care episodes that were delivered only by nurses with no doctor involvement. And you can see there that the overwhelming majority of care components of the care cascade at all steps were performed by nurses, and the contribution of nurses significantly increased over time. The poster I've highlighted here on the other side of the slide looks at the other range of services that people accessing hepatitis C care through the Kirketon Road Centre also utilised to enhance their capacity to get through treatment. So you can see that 45% of individuals had adherence plans and adherence support, 70% accessed drug and alcohol services such as methadone, drug and alcohol counselling for stimulant use and alcohol, 57% accessed housing and social support, half of them accessed HIV or sexual health care, a large proportion also accessing mental health care. And over a quarter of the people we provided Hep C treatment to amongst this population utilised our outreach services. So it's a big, integrated, flexible, multi-site, inner-city comprehensive care programme for these individuals. I wanted to talk briefly now about what sort of care is considered useful to people, particularly people who inject drugs, from a primary healthcare setting, which is relevant to, of course, hepatitis C and HIV care. So this is a narrative synthesis of the literature and models that have been published. This was submitted many years ago, but I think is still relevant. And you can see this is an extract from one of the data tables, but you can see across the top the major services that were considered important to be able to provide for an integrated bloodborne virus prevention treatment program for people who inject drugs from marginalized backgrounds. And you can see the staffing that might be required and the accessibility and acceptability. And you can see Kirketon Road Centre there as highlighted as being having many of these attributes. Now, we're fortunate in Australia to have very high coverage needle and syringe programs with over 300 needles per drug user per year estimated to be delivered. And that's been very comprehensively evaluated in our setting, demonstrating that not only is the intervention extremely cost-saving in terms of prevention of both HIV and hepatitis C, but it's also averted within our country between 10 and 25, well, between 2000 and 2010, 25,000 cases of HIV and almost 100,000 cases of hepatitis C. And you can see from the graph on the right that the antibody prevalence of HIV amongst people who inject drugs who don't identify as either homosexual men or bisexual men is less than 1% in the broad drug-using population. And that's really testament to peer-based organisation work and free access to needle and syringe programs across the whole of New South Wales and Australia. And of course, when thinking about HIV and hepatitis C care for people who inject drugs in our setting, we're also able, fortunately, to provide care for the other complications that may arise from drug use, such as endocarditis, abscesses, soft tissue infections, injecting-related injury and disease, and of course, crucially, interventions to prevent and manage drug overdose. But also important to consider the social and legal consequences of drug use in many settings, both in Australia and overseas. And two factors that clearly impact very significantly on access to healthcare, no matter how integrated your healthcare setting is, are going to be underlying stigma and discrimination, both in the general community, but also in the broader, within the healthcare setting, and also the legal response to drug use, and whether it's seen predominantly as a legal and criminal issue, or whether it's seen as a social and health issue, which is the model that we would prefer. So we work at Kirketon Road Centre under the influence of the National Drug Strategy in Australia, which and the National HIV strategies, and harm reduction has always underpinned some of the principles for delivery of this, this kind of care. So harm reduction is clearly a key component of integrated care for HIV and hepatitis C. But looking at data from the Harm Reduction International Organization, we can see here that in many settings globally, there are, and this is of about 160, 170 countries assessed, you can see that the number of countries that have access to any level of opioid agonist therapy or needle syringe programs is currently suboptimal, and there are very few countries in the world currently that have drug consumption rooms, which are also very important in my perspective in terms of engaging clients at risk of bloodborne viruses, preventing bloodborne virus infection, and also connecting those individuals into broader health and social care. And these, again, are just visual demonstrations of where, as many of you may be aware, opioid agonist treatment is available in the community, where it's available in the community and in jail, and also where it's not available. And this is similar data. So, as I said, there are only 12 countries in the world with supervised injecting facilities, and only one currently in the Southern Hemisphere, which is Australia, which has 2 facilities. The first of these was opened in Sydney, just 200 metres away from our clinic, in 2001. And we have many staff that work across both our service and the medically supervised injecting centre. And in fact, we operate medical clinics from the back room of the injecting centre itself. The injecting centre in Sydney has supervised over 1 million injections without one fatal overdose within the service, and responded to over 10,000 overdoses. It's also made many, many thousands of referrals to drug treatment, and also we've operated HIV dosing, hepatitis C dosing, testing and assessment from the injecting facility. So it's been a very key component of our integrated response, including harm reduction, testing, treatment, and reinfection testing within this local population. Of course, many of you be aware, the World Health Organization also published guidelines for HIV prevention, diagnosis and care for key populations, such as people who inject drugs and may be at risk of hepatitis C. An integrated service provision, such as the one that we're describing today, is identified as an ideal for service delivery wherever possible. And these are the recommendations from the WHO for services for people who inject drugs in an integrated, comprehensive harm reduction and care package. And we try very hard to make sure that all of these things are available across multiple locations through the network of services that we operate. So I wanted to finish off by just giving some examples of how we've evaluated our integrated care model. And how we've used that to demonstrate effectiveness for prevention, treatment, and care for people with hepatitis C and HIV. So first of all, we established a feasibility and acceptability adherence program, looking at dosing daily from our opioid agonist treatment program, but crucially, not requiring people to be on opioid agonist treatment to be able to come into the service each day and receive their hepatitis C and, if necessary, HIV medications. So we wanted to use the infrastructure of our daily methadone and buprenorphine program and leverage that to allow dosing for other bloodborne, for other complications of opioid use, such as bloodborne virus infections, without requiring that person to also wish to be or be eligible for opioid agonist treatment. So that was an interesting piece of work, which has demonstrated that this is very feasible. I already showed this graph, but we looked very carefully at the sort of treatment and adherence support that most allowed people to get through treatment and end up with sustained virological response at week 12. And we found that, and looked hard at parameters related to homelessness, type of drug use, other services accessed, and mental health issues. And we're able to demonstrate good adherence to treatment and good virological cure through access to the integrated care programs. There has been little work done on PrEP and HIV amongst people who inject drugs in Australia. And so we wanted to try and connect these two issues. And so also through engaging people with multiple issues into the service. We're able to assess the needs, perceptions, risk profile, and risk modification potential for people who inject drugs who might be eligible for PrEP. And we also wanted to integrate hepatitis C and opioid overdose prevention, recognizing that although a lot of energy and focus currently in Australia is on hepatitis C identification and treatment, many of the individuals that we see actually have a higher shorter-term risk of opioid overdose and death. And so by incorporating take-home naloxone into all of our hepatitis C program service delivery, we were able to not only impact on the long-term morbidity and mortality of these individuals through curing hepatitis C, but also provide an evidence-based harm reduction intervention which may benefit them in the short term and reduce the likelihood of them and their friends and family dying of opioid overdose. And finally, just to have a look at data from Australia. So these are not all patients of our service. We contributed a modest number of patients to this overall large cohort. But what we found through the delivery of multiple service models, including integrated care models to populations at risk of both HIV and hepatitis C, is through treatment access and integrated care, the prevalence of hepatitis C RNA in people who are hep C and HIV antibody co-infected has reduced over time from 82% of those individuals being RNA positive to just 8% of people living with HIV who have been exposed to hepatitis C still being viremic by 2018. So that's a big population level impact, and we're beginning to see, on the basis of that, reductions in incidence within that population. And I wanted to put one last slide in on how we have modified our service model and incorporated coronavirus testing, which has obviously impacted on clinical services, on community organisations and communities all over the world. So we initially needed to provide a lot of coronavirus testing to homeless and vulnerable populations to ensure that isolation of those individuals could be achieved effectively to limit disease spread. And so we used our mobile outreach bus, which is pictured here, to deliver pop-up COVID testing services using our outreach nurses and counsellors across a network of rough sleeping and social housing locations through the inner city, provided many hundreds of social work interventions and provided temporary accommodation, and also provided to those individuals going into temporary accommodation who needed to isolate until they got their coronavirus swab result, food parcels to help them not need to leave the accommodation, mobile phones so we could contact them and let them know of their results, positive or negative, and also hand sanitizers and masks to allow them to reduce the risk both to themselves and also to others in an ongoing nature. And then once we established the coronavirus testing model, we were then able to reintegrate our original workflow of providing HIV hepatitis C testing, needle and syringe program and basic primary health care to these populations. And so now we've managed to integrate coronavirus testing to this suite of other infectious disease interventions to this population locally in Sydney. So I hope that's given you a flavour of our model of care, our integrated model of care, and what we've perceived to be the benefits of that. I look forward to answering any of your questions about our service and integrated care generally. Thank you very much for your attention and enjoy the rest of the conference.